Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Habron Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m., and we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Healthcare Program through its Kentucky chapter. We produce this program because we believe health care is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer health care system for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts. Gene has recruited a special guest. Gene, I'll let you get it started.
Okay, I'm Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky, which is in a rural area. And what I say is only represents my opinion, not the opinion of Taylor Regional Hospital, nor the Department of Surgery at the University of Louisville.
Yeah, and this is Michael Flynn, retired surgical oncologist from the University of Louisville, surgery department. And let me also begin with the usual disclaimer that any comments I make on this program are my own views and do not represent the views of the Department of Surgery or the University of Louisville. We have a special guest today that Gene is going to introduce in just a moment. Our topic today is rural health. There's a lot of things going on in rural America today, and from a health standpoint, a lot of these really aren't very good. So, Gene, do you want to introduce our guest?
Yes, Don Henderson is a health and hospital administrator. He's been doing this for a long time, his whole career. He's been to multiple hospitals, including urban and rural hospitals throughout the Southeast, and he's now a professor of healthcare administration in Florida. Don, why don't you tell us a little bit about what you've done and your experience as a professor, and now also your experience in rural health. And before we get to rural health, I want to bring up an issue that actually really came to a head last week with some insurance companies. Go ahead, Don.
Okay. Well, it's thank you for having me today. And yeah, my current job is I'm an assistant professor at the Lake Erie College of Osteopathic Medicine, which is the largest medical school in the United States. There are 4 locations, and my offices are based out of Bradenton, Florida. But I also wanted to give the disclosure that any comments or things that we mention from my perspective are my own personal opinion and not the feelings of the LECOM University. So yeah, I was a hospital administrator for almost 40 years, and I retired several years ago to become a college professor in the field of healthcare administration. And my qualifications are that I hold a doctorate in healthcare administration from Central Michigan University.
Okay, tell us, before we get on rural health, recently we've heard that Humana had its star ratings dropped, and that its stock is price has gone way down. Also, Elvance, which is we know as Anthem Blue Cross Blue Shield, is losing money on Medicaid patients because the states have redetermined the eligibility of Medicaid. And then the third thing that got my attention last week was the CEO of CVS was fired because CVS was losing money. And it's my understanding that most of the money they're losing is from Aetna. CVS owns Signify Health. They own a pharmacy benefit management company. and then they own Aetna in addition to their pharmacies. So, Don, we've talked about the these problems before, but how do you react to this? And I think is it predominantly because of Medicare Advantage, or what's really going on?
Well, I think that, I was certainly in healthcare administration during COVID, and we saw a dramatic decrease in the number of elective procedures, surgical procedures, everything across the board fell to a very low level. And you could understand that because the public was very fearful, at least during the first part of COVID, that if they came in to the hospital, that they might get some infection, which has never happened. I don't think we got any cross infections during the 2 years of the COVID outbreak, but there was a fear on part of the public that they did not want to do elective surgeries during that time, which is certainly understandable, such as Aetna and Humana that provide Medicare services to the Medicare Advantage population. They obviously made money during that period of time because nobody was utilizing it and they were paid a fixed amount. Now, just the opposite has occurred over the last 12 months, is that a lot of the deferred procedures are being pushed into the current time frame. And so for the past year, they've seen what they call their medical loss ratio, which I think is kind of funny because, it's not really a loss, it's really healthcare that's being provided to people. But they've had a flip and utilization has gone up. And so that's created issues because if you compare their earnings to prior periods, which is what Wall Street does, they've had a decline in their profitability. And Wall Street is very fickle these days. There's not a lot of long-term investors. So if you have a bad couple of quarters, then stock price goes down and their profitability on average is down about 40% from the prior year.
Okay. What about CVS? They're losing money because of Aetna and the insurance company, the same reason?
Yeah, I think the overall number, this is kind of a rough estimate, but if you had a 15% loss ratio and they were making big money at a 15% loss ratio, recently their loss ratio has been a 10% loss ratio. So that 5% falls immediately to the expenses of the company, which results in lower earnings.
They're actually paying to provide health care, which is what they're supposed to be doing anyway.
Yeah, I think, we were excited when I was a hospital administrator, we had even a 5% margin. So the fact that you shouldn't cry for them if they had a 10% margin, that's a pretty good margin.
And I read that they were making up this loss with their pharmacy benefit managers. You want to tell us a little bit about that and how that works?
I don't really have a lot of knowledge of the inner workings of these companies. A lot of the stuff they do, because they're publicly traded, they have to disclose certain information on their quarterly reports, but I don't have a lot about the inner workings. I do think that it will be interesting in the next, there are different, the analysts on Wall Street have two different views. The view is that this is sort of a temporary thing that's related to COVID and it'll sort itself out. And then there's others that are more pessimistic. One of the things that's interesting is both Aetna and CVS are Aetna and Anthem and Elevance, as well as Humana, their roles are growing. So more and more people are signing up for this Medicare plan with these companies, which I think shows you that the shift is still occurring to what they call managed care Medicare. I think the shift is going to continue because of the extra benefits that are offered by these plans and the smaller out-of-pocket costs.
Gene, are you okay to move on to rural health issues?
Yes. Yes, Don, can you tell us a little bit about your experience in rural health care?
Yeah, Don, before you do it, our guests, and you've been on this program a couple of times before, we usually give our guests an opportunity to make whatever comments they'd like to make for as long as they'd like to make it on the topic, which is rural health, and then the conversation will begin. So the floor is yours for as long as you'd like.
Yeah, I think we should probably try to answer the questions you guys have put forth. And the first question you asked was why rural hospitals are important in the United States healthcare system. So right now we have about 1,800 rural hospitals, which is about 35% of the 5,157 total community hospitals in the United States. So certainly by numbers, rural hospitals are important to the healthcare delivery system. And at present, about 60 million people in the United States, or 20% of the total US population, lives in rural areas. Now that compares to about 30% back in 1980. So you can see, I don't know how long this trend is going to continue, but right now, the number of people living in those areas classified as rural is declining. And so rural hospitals are important to the delivery system of the United States because they provide vital services for people that are living in remote areas.
Well, can you tell us why rural hospitals are so important to small towns in America, and not only just from a healthcare standpoint, but from an economic standpoint?
Yes, well, having worked in several rural hospitals in the South, many times the hospital is the largest employer in the region or in the area. And of course, what's happened in many communities, and I'm not going to make a blanket statement for this, every community is different, but with the deindustrialization of some areas, the industries and the factories that were there have moved to a location. For example, Dr. Eugene, you could talk about this, but one of the largest Fruit of the Loom underwear plants in the United States was in Campbellsville at one time, and that moved offshore. So as these businesses have moved out of these rural communities, textiles is one big area. You could say even automobile manufacturing. You could talk about heavy industry. So as these things have moved out of the rural communities, the population has moved with them, the younger population. But in addition to this, the good paying insurance plans have also moved away. So what's left in a lot of these rural communities is mainly just people that get government insurance. It would either be people that are retired that have Medicare, or in some cases, if people are lower income, they may have qualified for Medicaid or what they call Obamacare.
Don, rural hospitals are closing. Can you give us and our listeners an overview of sort of why they're closing? I know that's a complicated bunch of issues, and where. Just kind of an overview, and then we can get into some other more specifics after you've done that overview issue.
I've done some research on this, so I'll just give you some of the statistics. So over the past 10 years, about 20 hospitals a year in the United States are closing, which means about 200 of them have closed over the past 10 years. And to give you the bigger picture, when I first started in healthcare administration, which again was 40 years ago, there were over 7,000 hospitals in the United States. We're down to just over 5,000. So you can see how that trend is occurring. Now, the rate in more recent months and weeks has really increased this year. And I'm projecting that instead of the historical run rate of 20 hospitals closing per year, for 2024, we're probably looking at 30 to 40. There was an article this morning, I read our hospital trade journals, and there's 2 hospitals closing in Illinois today as we speak. So this rate is increasing. In addition to the 200 hospitals that have closed over the past 10 years, studies have shown from the rural health coalitions that there are 700 more rural hospitals that have negative margins and are in danger of closing. They're sort of on death's door. So would you like me to jump into some of the reasons why I think this is happening, or do you want to stop and ask?
No. I think go ahead. That was, and the other part of the question is where. Are they closing in New England, out in the Pacific Northwest, or in the Southeast? mostly?
I don't think it's, Dr. Mike, I don't think it's just one area. I think it's really pretty much across the
Across,
United States
yeah,
in rural
okay.
areas.
Yeah, well, that's the question. Yeah, thank you.
Yeah, I think now that there are hospitals, you had mentioned in one of your questions, there's 10 states that have not adopted Obamacare, and we could name them if we need to, but they're mostly in the South. And those states that have not adopted Obamacare are seeing a slightly higher closure rates than those who have adopted Obamacare, but it's not so significant as you can pin that tail on that donkey. I mean, I think closures are occurring across the United States in rural areas.
Yeah, and my understanding, there are multiple factors. The issue of the businesses, the factories, the construction companies, whatever were working in these small towns have moved to wherever they've gone, to Mexico, Thailand, or wherever, and that leaves behind a population of people that are, as you said, are either on Medicare and Medicaid, which doesn't often cover the costs of the kinds of full service hospital that used to exist in those places. Is that a fair statement?
Yeah, so the main factors, certainly populations are declining in rural areas, and of course, if you have less people, then you have less need for healthcare. As a result of that, the hospitals are seeing declining volumes, and one of the big things that's come up, which I think you mentioned, is that there's a lot of transparency out there now for hospitals and their outcomes. And so if rural hospitals have some negative health outcomes, because the volumes are low there, the story goes out on the street a lot quicker in a rural community than it does in an urban community. So there could be quality issues due to the lack of resources. We talked about the loss of the industrial base. A lot of these hospitals were built in the 1940s to the 1970s under a program called the Hill-Burton Act. And there was an interesting senator by the name of Lister Hill. He actually is from Montgomery, Alabama, which is one of the places that I worked as a hospital administrator. And his first name, Lister, was for Dr. Lister, the famous French physician who invented antiseptic technique. But because his dad was a doctor, he was a very powerful U.S. senator, and he founded the Hill-Burton Act, got it passed. But the Hill-Burton Act ran out of funds around 1979, 1980. So many of the rural hospitals that we see today are 30, 40, 50, 60 years old, and their facilities have aged out. But then there's no way to replace them because the funds that were used to over 50% of the costs of the local hospitals were paid for by the federal government. So there's no rescue plan. The final thing I would say is the growth of regional health systems has really resulted in the business decisions that need to be made about whether the full range of services can be provided at rural areas. And larger health systems are under the gun as much as smaller health systems. So a lot of what's happening is downsizing and closures because the main system can no longer afford it. I know this has gone on for a long time, but let me give you a couple of other things. So there's labor shortages in rural facilities, acute labor shortages, doctors and nurses and support staffs. These hospitals are just, dying to get staff, but they can't find them for love nor money. And obviously the higher pay scales that were started by COVID resulted in wages going up for nurses about 30% in urban areas. And many of the rural hospitals can't afford to match the urban hospitals blow for blow on this. And finally, I know this is a long discussion, but many rural hospitals are being excluded from insurance networks. And when that happens, then the very few commercially insured patients that they have in the area are forced to go to larger cities where they can find a hospital that's in network, so they won't have a lot of out-of-pocket costs. So that was a long answer, Dr. Mike.
No,
I'd be happy to talk about any of that.
That was good.
Well,
Go ahead,
does
Gene.
does it help for a rural hospital to combine with a large healthcare system. For example, um, in in our area, a lot of hospitals have formed a relationship. For example, in Elizabethtown, which is not really a rural area, but they're part of the Baptist system in Louisville. And it's interesting that the University of Kentucky has bought two hospitals recently, one in Ashland and one in Moorhead, which really surprised me. Do you think this makes a difference in rural health care, and does it help the hospital and the mothership?
Yeah, I think there's always two phases to these hospital acquisitions. And the first phase is, I call it the honeymoon phase. That probably is 3 to 5 years, where the hospitals have been bought by the larger system. And really, a lot of what goes on in the first 3 to 5 years is just bringing the hospital up to speed, making sure that the information systems and the electronic medical records are up to snuff, and integrating many of the workers into employees into the new larger organization. So a lot of that goes on. Now, in the second phase, which would probably be the 5 to 10 year phase, I think the answer to your question, Dr. Eugene, is it depends. Because some rural hospitals have greatly benefited from these urban takeovers, and they've been able to keep themselves alive. Other people that have done this have chosen health systems that have failed. For example, a lot of rural hospitals were recently bought by a company called Steward, which is based out of California, and they made a lot of promises to the local community even a few years ago. And now, just in the last year or so, they've gone totally bankrupt. And now the local rural hospital sold on the street corner to the highest bidders, and then some of them can't reopen because there's nobody willing to buy a rural hospital if it's already in a challenged circumstance. So I don't mean to be wishy-washy, but I think every community has a different scenario, and it just depends on the deal that's being made, the contracts that are being signed, the commitments that are being made. I think in the long run, the larger health systems will bring the appropriate level of services to the community, but that may be dissonant from what the citizens originally thought would happen. So it's a two-phase thing, in my opinion.
Don, in my reading and podcast listening in preparation for this program, I ran across a term that I wasn't familiar with before, this critical access hospital, which is a rural hospital a situation, I guess the best way to put it. Can you kind of explain that a little bit, for me and for our listeners, and get into the funding of it? I thought it was very interesting the way this thing was is sort of set up, and anyhow, let me get your thoughts about that, and maybe you can educate me and educate our listeners about the critical access hospital, how it works, and how it's funded.
Yeah, sure. So knowing that the hospitals in rural areas have been challenged for a long time, obviously this is nothing new. In 1997, Congress enacted a law which is called the Critical Access Hospital Program. And it was a good deal for rural hospitals in that they could be paid more on a cost basis based on the number of Medicare patients that they are seeing versus being paid on a fee-for-service basis. So of the 1,800 rural hospitals in the United States currently, almost 1,400 of them, 1,400, have been designated as critical access hospitals. One of the reasons that the other 400 or others have not been able to make it under the wire to this program is that in order to be designated, there cannot be another hospital of any size within 35 miles. So that doesn't sound like a lot, but if you're in a mountainous area such as in Appalachia, that could be a very long way. But so a lot of hospitals weren't able to qualify. However, the critical access program itself has not been fully funded in that it provides a cost basis but it does not provide any additional funds. And of course, if you base reimbursement on your trailing costs, then that doesn't enable you to have enough surplus funds to be able to do things like hire new staff or replace your plant and equipment. So there are many, many critical access hospitals, 700 if you believe the statistics, that are on death's doorstep and cannot make a profit. Now in 2022, the federal government realized this and they passed the Rural Emergency Hospital Act. But this was sort of another devil's bargain because you can sign up for the Rural Emergency Hospital Act and get funding, but then the devil's bargain is that you have to close your hospital. You have to literally shut it down and go to outpatient services and emergency services only. So even though Congress passed this law back in 2022, only 29 hospitals have signed up for the program, which is not many out of 1,800 hospitals.
Don, can we go back just a minute to you talking about Steward system? Am I wrong? Wasn't that a bought by private equity that kind of helped them go bankrupt?
Yeah, I think they started out with good intentions, but you know, if your hospital's drowning, you know, if your local community's drowning, you're going to try to get a life preserver from wherever you can. And if a company comes in and says, even if it's for profit, and they come in and they say, look, we're going to keep your services going, we're going to, you know, keep everything in place, we'll keep your employees hired, you're going to take whatever life preserver you can get. But one of the things that Steward did was they immediately stripped the hospitals out of they did a deal where they took all the physical facilities of the hospitals and then they took them out to a leased organization. And that's one of the things, if you're desperate, that you can do is you can out the real estate value and then just lease back the facilities. So they did that, which resulted obviously in a lot higher lease payments. So to make up for that, they had to cut services and cut staff. So I'm not saying that every for-profit operator is bad. I mean, they're trying to do the best they can for their shareholders. But in this case, it was a combination of bad business moves. And now there are numbers of hospitals around the United States that are closed and they can't be reopened. So it's a very tragic situation.
Don, you know, I've got to disagree with you about for-profit, not for-profit, but private equity as having good intentions. Their main focus and goal is profit. And they want to get into something, leverage it, get 25% a year back, return on investment, and then sell the thing 5 or 6 years and move on to something else. This is a fundamental conflict of interest in private equity in healthcare. We've done a program on that here, and it is as bad as healthcare is in this country. That's going to make it a lot worse.
I think it depends, Dr. Mike. I think it depends on the company. You know, Hospital Corporation of America was founded by the Frist family in Nashville in 1972. So they've been around for 50 years. And so, yes, they are more expensive. Those hospitals are more expensive. Yes, there's more out-of-pocket costs. But in some cases, HCA has been working with rural hospitals in Tennessee and Kentucky and in the region and West Virginia, places that most people wouldn't go in the rural areas of West Virginia. So they've been doing their thing for 50 years or more than that.
Well,
so,
we've had experience with them here. They ran University Hospital for a number of years, and it was a disaster. The University Hospital is now run by its own not-for-profit system, the Board of Governors. They're doing really very well. They've incorporated one of the other hospital systems in with it, and they're actually expanding and building a hospital based upon the revenue that they've collected from just running a good not-for-profit system. When Columbia HCA was running it, they were sucking as much out of it as they possibly can because that's what they do.
Yeah, I'm not disagreeing with your own local situation there, Dr. Mike, but the other side of this is that academic medical centers can get access to fund, under the Medicare and Medicaid programs that for-profit companies can't get. So it may be for Louisville, that's the right answer, but there are other rural communities around the country, which I could certainly point some out, that had their hospitals almost dying and then they were rescued by HCA. But every situation is different. I don't want to characterize anybody as evil, but you're entitled to your opinion.
Okay.
Now, Don, does it make any difference if a hospital incorporates swing beds into their unit?
Well, yeah, I've had experience with a lot of different programs, and one of the things you can do, which I was a rural hospital administrator, one of the things you can do is take advantage of some of the cost exempt programs, because even though regular hospital admissions are paid for by a system called DRG, which is very complex, it's called diagnosis related groupings. And what it does is basically shifts the risk to the hospital for the care, based on an average payment. But there are some federal programs for hospitals that still have adopted cost-based reimbursement. So some of the examples, swing bed might be one of them. Another one might be to have a rehabilitation hospital. Some of the mental health and psychiatric services are exempt. And then skilled nursing facilities are also have a different reimbursement. So in order to diversify revenue streams, many rural hospitals have tried different things. There was a rural hospital I was familiar with in Alabama that's still operating down in South Alabama that gets more revenue from home health services than it does from the hospital. So there are ways to diversify the revenue stream if the management is astute and takes advantage of these programs.
We have a hospital in Greensburg that's a critical access hospital, but they also have long-term rehab, long-term care, and have patients on ventilators and dialysis. So they seem to have done quite well, and they've actually built a new hospital. And I don't know what their finances are, but they seem to be doing well.
That's very encouraging, and certainly local hospitals, if they want to remain locally owned and governed, they have to come up with some strategies like that. I had one administrator that I knew that went out west to a hospital in a town that there was a gold mine. So whenever they needed, it was a very small hospital and losing money, but whenever they needed money or equipment, they just went to the gold mine operators and got whatever they wanted donated to the hospital. So there are some unusual circumstances that are favorable, but generally each hospital is under duress in the rural area. I don't know of hardly any hospitals, except unless there's a gold mine in your town. They're all struggling, and the whole hospital industry is struggling. It's not just rural hospitals. The regular hospitals are struggling because of technology and the shift to outpatient settings.
Don, let me make some comments about the anti-abortion laws in Kentucky and how they seem to be affecting rural health, and I'd like to sort of get your views about how these issues in other red states affects rural health, because we have some very confusing and vague anti-abortion laws that have multiple effects. The individual specific direct effects have to do with treating women who have complications of pregnancy, and women who, for whatever reason, don't want to carry on a pregnancy. It affects the ability to train residents. The College of Obstetrics and Gynecology has a requirement that the residents who are qualified to sit the boards have to have some training for that. So if you're in Louisville or in Kentucky and in an OB residency training, you've got to go somewhere else to get that kind of training. The other consequence is that we've got fewer and fewer residents applying or applications for residencies in obstetrics and gynecology here. People, qualified obstetricians and gynecologists who have finished their training are not coming here. And some of the ones that are here, for all the reasons I've mentioned, and the risks of trying to practice obstetrics and gynecology in an appropriate way, and the risks are leaving, and we're slowly turning into a maternity desert. I think that's happened in Idaho, and there's some issues going on, I think, in Alabama and Mississippi. It seems to me that these issues are self-inflicted in some of the states that are going to be the worst affected by these issues piled on top of the other issues of rural health. I don't want to rant on for another 15 to 20 minutes, but I'd like to hear your thoughts about that.
Well, I think the whole field of obstetrics and gynecology, and I would even include pediatrics in that, it's becoming a larger and larger mismatch with rural hospitals. There was a study that was done, I think, in the last year from Harvard University, that 200 obstetrics programs have closed, primarily in rural hospitals, but in other parts of the country as well. So with these 200 programs closing, the question is, why is that occurring? Well, one of the issues is that you've got the majority of women who deliver in the United States right now are covered under the medical assistance program. It's certainly that way in many places. And the Medicaid program, which is also known as Obamacare, pays you at about 50% of your cost. So how do you what we did at my previous hospital I was running here in Florida, in a rural part of Florida, we had to do all kinds of exotic things to keep the obstetrics program going. But there is, there's technology factors, there's the declining population in rural areas, and there's the fact that the payer mix does not support the obstetrics program, so it has to be cross-subsidized. And if you have enough money to cross-subsidize it, it's great, but if you don't, the other thing that's happened, which I'm sure you know about, Dr. Mike, is the whole laborist thing. Are you familiar with laborists?
I'm sorry?
They call them laborists. It's where the obstetrics and gynecology has gone to a hospitalist program, just like they do for regular admissions. Most people are not aware, but if you get admitted to a hospital these days, 80% of the time, you're going to be admitted to a hospitalist service. Well, in the United States, because of all these factors, there's been the growth in what they call laborists, or specialized OBGYNs who stay in the hospital and deliver babies. The same is true with pediatrics. So what's happened is that for the hospital to be able to afford an OBGYN living in the hospital 24 hours a day, 7 days a week, it's much more costly than having the doctors come in from the outlying areas. So all these factors have created, like you said, it's an obstetrics and pediatric desert. And the large cities are the only ones that currently can afford to keep these obstetrics and pediatric practices going as far as hospitalizations are concerned. So I'm frankly don't know the answer to this question without some kind of significant government policy or some subsidy. I don't know how we're going to solve this problem.
Yeah, I was not aware of the term laborist. That's a new one on me. Thank you.
That's where if you go in and have a baby, there's a doctor there in the hospital who delivers baby, and it may not be somebody that you've ever seen before.
Correct.
I don't like the system, but they're doing it in several hospitals in Kentucky and some semi-rural areas in Kentucky. I think I always like the continuity of care. You see obstetrician, and that obstetrician delivers your baby or one of his or her groups. But that's changing mainly because doctors don't want to be on call all the time.
Correct.
Well, how many hospital laborists would you have to have in order to provide the service? You've got one person on 24 hours a day, 7 days a week.
Yeah,
That's
imagine.
got to be a killer.
It's true for pediatrics and neonatal care as well, right?
Yeah.
Because you've got to have at least 4 to cover 24/7.
Yeah.
You've got to have at least 4. And remember, the women that are coming in have insurance that pays you at only 50% of your cost. So the hospital's system has to subsidize that. Now, some of that can be done by residents and students, those that are in residency, but those hospitals that don't have very big residency programs have to go out on the open market. And you can imagine for laborists, it's largely semi-retired obstetrics and gynecology folks that do that towards the tail end of their career. But it's good for them because they can get paid, for every hour they're working. It's like an emergency room, they get paid whether any patients show up or not.
One of the things that's in Kentucky, the problems we've had with the new abortion laws is somebody comes in with a complication of pregnancy, for example, a ruptured membranes in the second trimester, then we're having to send them out of state. And we got a lot of patients from here that can't afford to travel to Illinois. I know of one patient that was sent all the way to Chicago, and that's creating a problem. They're going to have to change the law so that patients with complications of pregnancy can be treated like we always have in the past.
Now, there was an amendment on the last legislative election, I think 2 years ago, about whether abortion should be returned to a legalized status in Kentucky, and it was passed by 60% of the population in Kentucky, and there was a similar situation in Kansas, another very conservative rural state.
Yeah, I think it's up to the medical societies of each state. In Florida, I don't know how this is going to come out, but in Florida, there is in Florida, you have to get a constitutional amendment. There is a constitutional amendment on the ballot for Tuesday, this next Tuesday, that covers some of the issues you guys have talked about. But I think if you go too far one way, then the pendulum needs to swing back and do the best thing for mothers. That would be my own opinion. But I think each state is going to have to fight that out on their own, and the medical societies can be very involved in getting. There's been many bills passed through the years that are wrong or crazy or whatever. So you guys need to band together and use your state medical society. And there's not very many degrees of separation between you guys and the legislators. So you're going to have to, lead the charge to get that fixed.
Well, the problem is the legislators don't understand health care. I mean, this has been recognized a number of occasions, and attempts to influence their activities in Frankfurt has not been very successful. The last program we did actually was a program on women's reproductive rights. And we learned a lot about some of the activities that are going on to try to influence the legislators, but it's not going very far.
Well, one of the problems is that doctors have not ever been very active in the political arena, and they don't like to be.
Yeah.
And my 46 years of practice, the KMA spent huge amount of time trying to get people engaged and give money for the PACs, and a very small percentage of doctors have become involved in that. There's lots more other paramedical people who are involved, like optometrists, nurses. They do much better than we do, and it's our own fault. I just told a medical student and a doctor just yesterday that they said they were talking about the current election. They said they didn't like politics. I said, well, you don't have a choice. You've got to get involved in it, because I see in the future the government's going to be more and more involved. Speaking of the future, Don, what do you think is going to happen with U.S. medical system and rural health care and after the election?
Yeah, I think, some of the biggest issues we have as a country are trying to address the coming shortage of doctors and nurses. There's, I think it's one of the statistics is that 25% of the active licensed practicing physicians in the United States are over age 65. And what happened was Congress passed another law back in 1997, which restricted the number of residency slots. But of course, the United States population has grown from 200 and some million to 300 and some million in that time frame. So the population is growing. The number of people over 65 has increased from 12% to 18%. So we've got the aging and the graying of America. We've got nothing against anybody in the room here, but we've got the aging and graying of practicing physicians. And somebody's going to have to address this. It's going to require a change in health policy. I was on the board of the Florida Hospital Association for at least 5 years. And when I went to the state legislators in Florida and said, what is the health policy of the state of Florida? They would say, save money, lower costs, save money. And so that's our health policy in Florida right now, to save money and lower costs. And they treat healthcare like a business, which, as you know, there's many aspects of healthcare that are not synonymous with business philosophies. So I think we've got to address the national labor shortage. I think we have to think about using technology to help us as a country. And so, I think I mentioned this during one of the previous podcasts. The Medicare Trust Fund is due to run out of money sometime in the next 5 or 6 years. Social Security will run out of money. So we can't just keep doing the same things we've done. There will come a time where we can't kick the can down the road. But if you want my immediate opinion, I think both candidates who are running for president will kick the can down the road until someone holds them accountable or until the United States reaches a fiscal crisis, and then something's going to have to be done.
The most fundamental issue in this country about healthcare is what you've just mentioned, the fact that healthcare is run as an industry and a business, not run as a system. Now, other countries have addressed the issue of rural health in different ways. Canada and Australia both have the same issues of access to health care as in the U.S. Now, Australia has a task force called the National Rural Health Alliance, and Canada has a task force called the Rural Roadmap for Action to address these issues. To my knowledge, there's no national, and I'm asking this question because I don't know, is there any national kind of task force or group that sits and focuses on access to health care and the issues that exist in rural America?
I agree with your comments, Dr. Mike, as I think, I also know that the UK, United Kingdom, which is the immediate area around England there, they also put together a national health policy group under a famous physician there and recently came up with new goals. So there is no current health policy in the United States that's overarching and overreaching.
Yes.
Now, all those countries that you just named have universal health care and a government-run system. So I certainly would not advocate for that, but it's going to require somebody to take a hard look at the whole healthcare system, and health reform is necessary. I think I talked about this in previous podcasts, is we want to maintain the best of the healthcare system, which is that private delivery of healthcare is really superior for the delivery of medicine. We don't want it to become a government-run monopoly.
Well, neither Canada nor Australia has a system that runs it all. Britain does. In Australia and Canada, it's simply a matter of a government-run insurance program.
Yeah.
They don't run the hospitals in Canada. There's a surgeon in Hamilton, Ontario, who's been He's done 2 programs with us, and his ability to practice is so much simpler than ours, dealing with all of the issues related to the for-profit health insurance companies.
Yeah, so we want the health system to remain private, which is one of our strengths.
Yes.
But we have to reform the payment system. We do have to have universal health care, and we do have to, at some point, have to make the painful decision of standardizing reimbursement and administering it through a government source, because that would cut out 10 or 20%. Dr. Eugene in previous podcasts talked about the fact that 30 to 40% of healthcare expenditures are wasted in the United States. So the only way to begin to get the waste out of the system is to reform the payment structures. And, there is already a MedPAC committee that's made up of, I think it's 32 doctors. So I think that first and foremost is health policy. Once that's done, then a serious commitment to health reform with universal health insurance, but not universal government takeover of healthcare. Those are all things that are on the horizon, but I'm extremely skeptical that nothing will happen until a crisis occurs.
Well, the problem in this state is that the ideologic Neanderthals in the legislature who passed all these vague and confusing abortion laws are there's no way in hell that you're going to get this kind of a thought process going in that belief system. So I agree with you absolutely, but I just don't see this happening anytime soon. I don't know, Gene, you got any thoughts about, you live out there in rural America, so you're closer to it than I am.
We're doing pretty well here. About 2 years ago, this was not outside influence. We had an administrator who almost destroyed our hospital, but we're coming back and we're doing pretty good. Now, we used to make margins of around 4 or 5%. Now we're out to 1 or 2%. But we're coming back. We're doing robotic surgery. We have a very good cancer center. And one of the things that I've always done in my practice is we had a very good relationship with the University of Louisville. And then right now we have a very good relationship with our cancer center and the University of Kentucky. So we can do most of the cancer care here. If we have something that needs to be done elsewhere, particularly University or Louisville, we have a close communication, and those patients can be taken care of post-op here, or if they're getting chemo somewhere, that we can follow up with them here. Most of the patients that go outside or someone that requires complicated procedures like pancreatic surgery, or someone who's getting a bone marrow transplant or something like that. So so far we've done pretty well. I hope we can continue to do that. It's interesting. The main thing that's changed here is primary care. I don't know the exact number, but I think that at least 70% of the primary care is being done by a nurse practitioner. And my experience has been that they do a pretty good job.
Now, Gene, some years ago, I sort of vaguely remember that there was some kind of a program in Kentucky where the medical students had part of their tuition, the cost of going to medical school paid for if they spent some time out in rural parts of Kentucky. I don't remember the details. Is that still in existence?
To my knowledge, it's not.
Yeah.
Most hospitals, in order to get doctors, will pay off student debts if they stay a certain amount of time. They'll get so much money per year, and it's usually 4 or 5 years. And we're able to attract physicians because of that.
Don, your thoughts about increasing the the number of primary care physicians in the environments where you've been an administrator?
Yeah, I think obviously you need to cooperate with your state medical schools. Again, one of the things that's maybe not popular in some circles is osteopathic medical schools are growing pretty rapidly in the United States right now, and they're 70% of their graduates are going into primary care. So in states that have rural areas, they're beginning to fill some of the need. But I also think that there should be a statewide and also a federal policy, because you can't really train doctors. You can put them through medical school, but you can't put them through residency unless you have enough residency slots. And residency slots are maxed out in all educational organizations across the country, and no new residency slots are being authorized. So that would be another policy change that could be very helpful.
Absolutely. Can you imagine that you spent 8 years of higher education and you've got a $250,000 debt and you don't match and you can't get in a residency program? What a bad deal that would be. I understand that most of those people can get into a residency a year or two later, but still, that is really a terrible problem. I ran into a lady a few months ago who was in that situation, and she finally did get a residency, and she's doing very well in the surgery program.
Guys, we're getting close to the end here. Don, Paul's going to take us out in a minute. Don, we're going to give you an opportunity to make whatever final comments you'd like to make. I want to thank you again for coming on. You've done a number of programs with us, and I've always learned a lot from listening to you. So if you want to make some final remarks, and then Paul's going to pull the switch.
Well, to summarize, I think we're kicking the can down the road right now. So, I would encourage everybody listening to this podcast to work with your local legislators, talk to your local representatives, not only about some of the issues we've discussed, but about the future of healthcare. And we really do have to rely on our elected leaders to, just like in so many other countries, we have to develop a national health policy and go from there. It's been my pleasure to be on this podcast, and I wish everyone a good Halloween and happy holiday season.
Well, thank you again for coming on. You're a great guest. Paul?
Don, thank you again for another very, very informative appearance on our program, and we do hope to have you back again. Thank you to Mike and Gene for helping to continue to put this show together. We get information here on our healthcare system that is just not available anywhere else. So to our listeners, tune in again next time for Single Payer Healthcare. Thank you.